So a few logistics before we get started here. We're going to be asking 3 poll questions during the webinar, so if you could take a moment to answer, we would appreciate it. You can ask any questions during the webinar by entering your question in the question box of your control panel. And also, after the webinar, we're going to be sending out an ebook of the slides, so stay tuned for that. Our agenda today, we're going to do a brief MIPS overview. We're going to talk about the 2018 macro program year. And then we'll talk briefly about the future of healthcare and how it's related to value-based care. And then finally, we will talk about our Spectrometrics eMeasures 360 for macro platform and how that can help providers implement the MIPS program. So without further ado, actually, I'm going to take a step back. Our speakers today are Mark Bryant. Mark is Director of Sales at Spectrometrics. And also on today is Christine Wismer. She's the Senior Business Analyst at Spectrometrics. She's actually filling in for Dr. Raj Lakapal today, who is unable to attend. He was called away on short notice this afternoon. So without further ado, I'm going to hand it over to Christine.
Thank you, Nathan, and I'm going to thank everyone for taking the time to attend today. So first going to start out with a little overview of MIPS. That's fine. Okay. All right, so we're on slide 5, right? Okay, so I'm going to start with a little overview of MIPS. So first let's talk about where we are today. So currently we're in what's termed as program year, performance year, calendar year 2017. This is the first year of the MIPS program, QPP year 1. CMS refers to this particular program year as the transition year. Given that it's the first year of MIPS, CMS is essentially allowing some flexibility in terms of reporting. They are essentially allowing you to report a minimum amount of data, and then you will essentially avoid the negative payment adjustment. That minimum amount of data could be as low as or small as reporting 1 quality measure for 1 patient. In terms of the structure of the program, whether it's in the current year that we're in, program year 2017, or future years of the program, the structure of the program is pretty much the same. The program year that you're in, or the performance year that you're in, what it will do is essentially how well you perform will impact your Medicare reimbursement in what's considered the payment year, which is 2 years in the future. So for example, currently we're in program year 2017. So in payment year 2019, how well you did MIPS this year will actually affect your Medicare reimbursement in that payment year 2019. So that's part of the structure of the program. That hasn't changed. The way that your payment adjustment will be determined is tied to your MIPS score. And that MIPS score, again, is how well you perform in a number of different MIPS categories and measures. The way that CMS has structured this particular program, QPP and MIPS in particular, is that it's a budget neutral program. By that, I mean that the penalties that they take from providers and from organizations are redistributed to providers that have success in the program. So this is what CMS will have. It's a requirement of the law. In addition, CMS has also put some seed money into place and funded some exceptional bonus reward pools that we'll get into a little bit later. So I guess one of the things to note is that we're currently in the performance year or program year 2017. This performance year ends at the end of the month, and you have until the end of March to actually submit data. So if you still have a chance, you're not out of luck. If you haven't made a decision about what you're going to do this year, you still have that opportunity. And I would strongly suggest that you take advantage because, as I mentioned, CMS with their Pick the Pace have put some rules in place or reporting options in place that you can essentially satisfy the requirements and avoid the penalty. Moving on to 2018, CMS is ramping up with this program and they're removing that flexibility or they're removing that Pick the Pace, so that will no longer be an option. So really, I'm going to kind of dive into some of the 2018 calendar year performance year rule, I guess after a poll.
Thanks, Christine. So we're going to launch our first poll now. What is your quality performance reporting period for program year 2017? Launch the poll. The choices are 90 days data, full year data, minimum data, or pick your pace, option 1. Not reporting quality performance category in 2017, or not reporting MIPS at all. Give everyone about 30. Okay, I'm going to close the poll. I'm going to share the results with everyone. It looks like not reporting for MIPS at all and full year of data both got 33% of the respondents, and then 90 days data and minimum data both got 17. So two ties there. And back to Christine.
Okay. All right, so now I'm going to kind of dive into the 2018 program year, which is coming up very shortly. Next slide, please. So as I mentioned, the way that this program is structured is that each clinician will receive a MIPS score, and your MIPS score will be based on how well you perform in a number of performance categories. And this particular slide or chart shows what those performance categories are. There are 4 that are in play. The quality performance category, that is a replacement for the PQRS program. The improvement activities category, which is a new category that CMS came up with for the quality payment program. The advancing care information category, which is a replacement for the Medicaid EHR incentive meaningful use program. And the cost category, which is a replacement for the value-based modifier program. So given how well you perform in each of these categories, CMS will essentially calculate your score by summing the result and weighting them with these weights that are shown here. In 2017, you can see that the weights are 60% for quality, 15% for improvement activities, 25% for the advancing care information, and the cost category has a 0 weight. So that's just going to be provided for informational purposes. CMS will provide feedback as they've done in the past in the PQRS and value-based modifier program. And I encourage you to take a look at your existing QRUR that you have out there for program year 2016 that was made available to also see how you're doing in this cost category as kind of future reference. In terms of what's changing for 2018, as you can see, CMS is making some adjustments, not only in the weights, but also the durations. As I mentioned, in 2017, CMS was offering some flexibility given that it was a transition year, and that flexibility allowed you to report a limited amount of data. So you can see that it says 90 days. Most of our clients either report a calendar quarter or they report a full year of data. So you don't actually, for 2017, have to report a full 90 days. But again, if you want to get better than the performance threshold, we would suggest that you don't take that option. But in terms of advancing care information and for the improvement activities, a requirement of a minimum of 90 consecutive days is required for reporting. So in taking a look at what was in place for 2017 and then comparing that to 2018, you can see that CMS has done some adjustments in the weighting. They've actually weighted the cost category 10% and taken that from the quality category and have left the improvement activity and advancing care performance categories as is in terms of weighting. Another thing that you would take away from this particular slide in comparison is that now quality must be reported for a full year. So as I was mentioning, you had some more flexibility and CMS cut you some slack in the current program year of 2017, but that's no longer going to be in place in 2018. So starting January 1st, the provider's workflow and the actions will count towards your quality measures and your quality score for this particular performance category. Next slide, please. So I'm going to delve in a little bit more specifically into the cost category. This seems to be of a lot of interest to our clients. As I mentioned, the weight for this particular category in the current program year of 2017, it was weighted at 0%. Now it's weighted at 10%. This came as somewhat of a surprise because in the proposed rule for 2018, CMS had originally weighted this at 0%. And so when the final rule came out and the weight was at 10% versus 0%, people were surprised at that. The rationale, I think, behind this is that by law, this particular performance category must have a 30% weight by program year 2019, which essentially affects payment year 2021. And given this, CMS didn't want it to have such a steep ramp up, so decided that they would incorporate this weighting at this point in program year 2018. In terms of diving into what are the specific measures that are involved in this category, they should be familiar to those that are familiar with the QRUR report and the value-based modifier program. They're the two measures that are the Medicare spending per beneficiary, as well as the total per capita cost. And that was why I recommend that you access those reports in order to sort of see how you're doing now and as a predictor for how you'll do in the future. CMS does the calculation for providers for these particular measures, so there's no data that has to be reported to CMS, and this data will be based on the claims data that the providers submit, and the performance period will be the entire year. So again, one good thing to do would be look at some past data in order to kind of do a prediction or figure out what you want to put in place for the future. Another key item to mention is something new for program year 2018, and that's called improvement scoring. And what this is that CMS is essentially offering a bonus to the performance cost category if the provider or if there was shown improvement on one or both of these two measures from the prior year. So if you had improvement from program year 2017 to program year 2018 in either the Medicare spending per beneficiary and or the total per capita cost, you can get up to 1% bonus towards the MIPS cost category. Next slide, please. Some other key changes that I want to just touch on. One of the things that CMS was concerned about is addressing some of the burden or the concerns that small practices had about this program. So CMS has put some things in place in order to address this. One item is basically upping the values for the low volume threshold. So as you'll recall, the low volume threshold is the threshold that is used to determine whether a clinician or a group is eligible or exempt from MIPS. So if a clinician or a group has less than 90K or $90,000 in Medicare Part B allowed charges, or sees less than 200 Medicare beneficiaries, then they're exempt from MIPS and they don't have to participate. This is in contrast to the current program year of 2017, where these values were much less. Basically, the threshold was 30K and 100 Medicare beneficiaries. So this should actually have a lot, many small practices now will be exempt from MIPS and won't have to participate. Two other items worth mentioning to small practices is that for this program year of 2018, CMS will give an additional 5 bonus points for being a small practice. A small practice is defined by CMS as having 15 or fewer eligible clinicians. And then the final thing that I've noted on this particular slide is the addition of a new reporting option called virtual groups. And what virtual groups is it allows solo practitioners as well as clinicians in groups of that have TINs with 10 or less clinicians to essentially band together and take advantage of some of the economies of scale and some of the advantages to group reporting that some of the larger organizations are allowed to participate or take advantage of. So one thing about this particular option, if this seems like something that would be attractive to you, you have until the end of this month in order to form or to become part of this virtual group in order to participate in program year 2018 in this way. Next slide, please. Some other key things to point out are related to some bonus points that CMS is making available. The first item is to your final score. They're recognizing that you should be rewarded for treating complex patients, and this is based on your HCC as well as your dual eligibility ratio. That's the determination that's being used in terms of looking at your beneficiaries under those 2 categories and awarding additional points for that. Another bonus that they've put into place is for the quality performance category. And in this case, it's an improvement scoring bonus. So in some ways, it's analogous to the improvement scoring bonus that's in the cost category. Some of the differences are that whereas the cost category basically sees if you made improvement in each of the measures and rewards whether improvement was made on one or both of the measures, the quality category improvement scoring is at a category level. So it basically looks to see the measures that you reported last year in what will be last year in 2017 as compared to the quality measures in 2018 and see if you made improvement. And if you made improvement, CMS will award up to 10 bonus points to your quality performance category for that success. And the final bonus that I wanted to highlight was related to the advancing care information performance category. And this is, again, 10 points. And this is trying to encourage organizations, practices to providers to adopt the 2015 certified EHR technology. This requires not only use of the technology, but also use of the measures that are based on meaningful use stage 3. So if you essentially do that and use that for your entire reporting period, which has to be a minimum of 90 days, then you'll be awarded 10% bonus and your ACI performance category will be out of a possible 165 points as compared to this year of 165 as compared to 155 this year. Okay, next slide, please. So this slide is really saying, you know, we've talked about the performance categories, we've talked about how to generate your MIPS score, which is basically the weighted sum of the various the 4 individual performance categories. Now let's talk about how your score translates into your payment adjustment. The way CMS has structured this program is to say that they have set a threshold, and this threshold varies every year. They refer to this threshold as the performance threshold. And this is the point that if your score is at that performance threshold, then you essentially won't have any impact to your Medicare payment adjustment. You won't have any impact to your Medicare reimbursement. For program year 2018, CMS has set this threshold at 15 points as compared to the current program year that we're in, where it's set at 3 points. So you can see that CMS is ramping up the program. So in taking a look at this chart, you'll notice that if you have under 15 points, between 0 and 14 points, that then you have you can have a negative payment adjustment against your Medicare reimbursement of up to 5%. Again, in contrasting this to what we have currently for this program year, it's 4%. So again, you can just see that CMS is continuing to up the ante. Looking about how we can dip into some positive payment adjustments, if you have a score of between 16 and 69, then your payment adjustment will tap in and give you a share of this budget neutral reward pool, which is essentially the money that they take in penalties from the other providers and then gets redistributed to providers that basically have success with MIPS or exceed the performance threshold. If you have a MIPS score that exceeds 70 points, which is known as the exceptional bonus threshold, then you can actually tap into two reward pools that I alluded to earlier. One is the budget neutral reward pool, and you'll also get a share of this exceptional bonus pool that CMS is funding with $500 million for this year. Next slide, please. So this particular slide, I guess some organizations or providers might say, you know, you're telling me about these different reward pools, but from what I hear, it doesn't sound like the incentives are that large. So why should I participate? I mean, is it really enough for me? Can I still sit on the sidelines and get by if I don't think, you know, it's worth my while? So, I mean, if you're not convinced about the impact to your Medicare reimbursement and essentially the shares that you'll get of the various reward pools, if that's not enough to entice you, then I guess one thing to consider is that regardless, CMS will be publishing all clinicians' MIPS scores. And the MIPS score, as shown in the previous slide, will vary between 0 and 100. And those MIPS scores will be available on the Physician Compare website, and other third-party websites we expect would basically utilize those scores in, you know, possibly some ratings or for some other websites. The other thing to note is that CMS will be publishing for download both the ACI and the quality measures. So again, these are things that will be publicly available. And as this particular slide shows, studies have been done that consumers and patients are viewing these online websites and using them as one indicator and one decision factor in terms of making selections about providers. So this type of information will essentially stay with you regardless of how much money you may get to or what impact it may be on your reimbursement. Next slide, please.
Okay, thanks, Christine. We're going to pause again and do our second poll question. What do you expect to be your biggest MIPS reporting challenge in program year 2018? And the choices are collecting the data necessary to measure and report, identifying measures or activities reflecting best performance, forecasting MIPS score and payment adjustment, and finally identifying resources in MIPS for MIPS. Okay, so I'm going to close the poll now. Share the results. So 38 of you selected collecting the data necessary to measure and report, 31% identifying measures or activities reflecting best performance, 23 forecasting MIPS score, and 8 identifying resources for MIPS. Thank you, everyone, for participating. Back to the webinar.
Okay, so I'm going to talk a little bit about value-based care. Next slide, please. All right, so if I take a look at this slide, I think the point that I would like to get across is that MIPS really shouldn't be viewed as a burden. It shouldn't just be something, added to the provider's to-do list, yet another reporting program, but instead should be really viewed as a reward for hard work. And what I mean by that is, for a number of years, providers have had to report for PQRS on the value-based modifier program. They also have many quality improvement programs that are internal to their organizations. They possibly use this data and they put interventions in place to basically have successes, whether it's in improving clinical outcomes like reduction in hemoglobin A1C levels, or reducing unnecessary costs, or reducing unnecessary readmissions, things like that. So they've already put programs in place, these interventions in place. And I think that you should really look at MIPS as basically saying, okay, now that I have these successes because of these interventions that I've put in place, reporting about them is how I'm really sharing these successes with CMS and really with the community at large. And CMS is now, based on those successes that I've shown that I have these improved performance and quality measures, et cetera, CMS is going to reward me through these payment adjustments, both in the budget neutral as well as the exceptional bonus pool. And then CMS is also going to make these successes publicly known through my MIPS score and through the actual public availability to download these measures and this other information. So I guess that's the way that I would look at MIPS. Hopefully not just, oh, this is just something else I have to do, but really it's in some ways sharing the success that you've had. Given that we're now saying that the patient or the consumer needs to take a more active role in their health care, sometimes incurring more of the cost than they had in the past. CMS is, wanting them to do more self-management, take an active role. In this case, they need to really be seen as in partnership with the provider, that the two really working together in order to achieve this common goal. In this case, CMS wants to be as transparent as possible and give these patients and consumers the most amount of information that they can so that they can make some good decisions in selecting the healthcare provider. Next slide, please. So for this particular slide, I think the message is really that don't really look at MIPS or the QPP program as an isolated program. Yes, I think you can agree that QPP is sort of a driving force in the transformation, moving from fee-for-service payment model into the value-based payment model. So that's true. I mean, only a few years ago, it was predominantly all fee-for-service, and you can see the progress that's been made in just a short time. If we look at it, more providers are joining ACOs, more providers are joining these alternative payment models. CMS is providing some incentives to do that with a 5% bonus if you're part of an advanced APM, and then you also don't have to participate in MIPS. CMS is introducing some additional advanced alternative payment models in the future, and they're also encouraging other payers, participation of providers in some of these other payer models, and basically rewarding that by saying that providers' participation in those other payer models will count towards exempting them from participating in MIPS and being part of an advanced alternative payment model. So they're encouraging them to do this. I think the bottom line is that CMS really wants to get this right. They recognize some of the concerns of providers in saying that, are the measures really an accurate representation of our quality and controlling costs? And they're putting together some new initiatives like the Meaningful Measures Initiative to try to better align measures, better align programs, and really focus on measures that are going to really offer value and really drive improved outcomes. So I guess if you haven't implemented a value-based strategy at this point, I think that you have to recognize that this is something that's not going to be just limited to the KPP program. It's something that's here to stay. You really want to have an effective strategy and a plan, and I think that it's important, if you haven't jumped in, to make sure that you jump in and take that to the next step. Okay.
Okay, thank you, Christine. So we're going to conduct our third and final poll question. What is your payment adjustment expectation for MIPS in program year 2018? I'm going to launch the poll. The choices are positive payment adjustment plus exceptional bonus payment, positive payment adjustment, neutral payment adjustment, and we are taking part in an APM. Give everyone about 30 seconds. Okay, we'll close the poll, share the results. So 8% picked positive payment adjustment plus exceptional bonus, 46% positive payment adjustment, 23 neutral, and 23 we're taking part in an APM. Thanks everyone for participating, and I'm going to turn the webinar over to Mark Bryant now.
Good afternoon, everyone, and good morning, and thank you for taking part in our webinar today. And I appreciate Christine's insight to open this up. And so for my part of the webinar, I'm going to talk a little bit about how we can help, both from guidance and also from a solution perspective as you transition to MIPS and beyond MIPS into other alternative payment models. So first, we believe that we can offer a solution that can assist you in attaining your positive adjustment, which ultimately will help you maximize your incentives, as Christine had spoken about, and put your organization in the best position publicly as the scores are published for that. If you don't have a solution, and by not having a solution, that's both from a technology perspective, but also from a collaboration perspective within your organization, that your teams aren't collaborating, your finance, quality, IT teams, to have a complete strategy to transition into MIPS. You take the risk of a negative payment adjustment, which could lead to not getting your full allotment of incentives, and also hurting your reputation publicly, again, as the scores are published. So where we can help, the first stage that we can help in is through what we call our readiness consultation or assessment process, where a team of our experts, like Christine from a business analyst perspective, and our client implementation managers, will walk you through an assessment process where they'll understand who are your eligible clinicians, understand their specialties or their interests, and help you select the right measures, especially around quality measures, that position your TIN, your tax identification number, to be able to maximize your incentives. So they'll look at these measures, they'll help you select the measures. We'll take in a sample amount of data, and that could be various data points, and I'll talk about that in a second. We'll analyze that data for any gaps. We'll identify those gaps with you, and we'll provide you reporting back up front that allows you to understand how you're currently doing with those measures you selected. Are they the right measures for your group of clinicians? Where are there gaps that you can start remediating, both from a data perspective and also from a workflow perspective? And so we're working with today many different data sources. So we can work with your organization to take in clinical data, to take in claims data. We're also working in other programs around survey data. We're integrating with HIEs and custom data sources. So we have the ability to aggregate that data, apply our Enterprise Master Patient Index to it to help create one patient record for you, normalize it, and populate an enterprise data warehouse. So therefore, you have the right data at your fingertips. And so one of the big questions we get is asked all the time is, how do you collect data specifically for MIPS? And so we kind of break it into three separate buckets here. So the first is structured data. So we can take in structured data directly from your EHR, and that can include QRDA1s, CCDAs, and any other type of structured format that can be produced directly from the EHR. The second piece is billing data. So we can take in your 837 Ps, collect that data to calculate the measures, and provide smart web forms for capturing any of what's called the G codes, the quality data codes that might be missing from the billing data in order to properly calculate that measure. So that's the second bucket that we look at. And then the third is non-structured data. And for this, we can build either custom interfaces to extract the data directly from your EHR, or we can provide other custom file formats that you can upload data to us. So once we have the data, we'll run our measures around that, and I'll talk through our measures in a second. We'll provide dashboards for continuous performance improvement, and I'll show you a couple glimpses of those. And we handle all the submission to CMS for MIPS. We're a qualified registry and a QCDR, so we can handle all those aspects for you and be able to report for MIPS. And as Christine had said earlier, as you start to look at other value-based care programs, we can help you align with those as well, see what data that we're currently getting that we can leverage, and look at other data sources that if you're transitioning into an ACO, or if you have a clinically integrated network as part of your health system, we can assist in those areas. So we have a library of over 400 measures today, and that's continuously being added to. We're ONC certified for all 29 hospital electronic clinical quality measures on the left-hand side, supporting HIQR, meaning for use, and also the Joint Commission submissions. And on the right-hand side, on the ambulatory programs, as I stated, we're a qualified registry and a qualified clinical data registry. We support not only all 64 electronic clinical quality measures, but as a qualified registry up to the 243 measures that were published in 2017. We have measures built to support clinically integrated networks, ACOs, doing a lot of work around Medicaid reform, particularly in New York State, and a lot of these measures are HEDIS-based measures, CPC Plus and STAR Medicaid Advantage as well. So whatever program you're in today and/or transitioning to, we're very confident that we could support your organization. So our process looks like this. So as I spoke about up front, there's an assessment process that at the beginning, at the kickoff of the relationship, we'll start to take in those different your data sources, run them against measures that we work with you to select. There'll be a remediation period. During that time, we'll be building out our portal that you'll then be able to go into prior to submission period to start looking at your measures on an ongoing basis and track your MIPS program overall. When we get close to the submission period, we'll allow you to go into the portal and choose the measures that best position your organization. You'll then provide us a report out of that system that we then format and we submit onto to CMS on your behalf. And this will continue as we build a relationship with your organization. You can go back in time and see past results as well through the portal. And to give you a little glimpse of it, we have a couple key roles within our application. The first is an executive role. The executive can have access, your leadership team, to see what your organization, your TIN, how it's currently performing in MIPS. So across the top, you'll be able to see what your total composite score is. That's broken down between the four key categories for next year: quality, advancing care, clinical practice improvement activities, and cost. You'll be able to see what the score is for each of those, how it adds up to your composite, and what your potential earnings or holdbacks might be based upon that composite score. And then you'll be able to break down for each of the categories below, and we're showing you a glimpse of the quality. Here are the measures that you've chosen. We baked in the deciles as the benchmark, so you can see per measure how the measure is performing against the published CMS deciles, which ultimately affects your scoring. So anything in orange is, has shown some performance, but it's below the top threshold, so you're in the middle. Anything in green, you've maximized out that particular measure. And anything in blue, that's for 2017, that's a measure that deciles were not published for. So any performance, you would get 3 points, so we just indicate that in blue. And then you'll be able to have customization within this that you can drill down on each of these measures to show trending month over month, quarter over quarter, to show what made up the measure results, to show clinician comparisons. So whether you're reporting as a group or individually, we can show you how your clinicians are performing against the measures that are chosen. We can do patient-level trending as well through that. And then to complement this role is what we call our analyst role or coordinator role, informaticist role, that goes in and gets into the actual patient-level details. So they'll look at each of the measures and be able to drill down in them to see, who qualified for the measure. Was the measure performance met? Was it not met? Why? And is there any data missing that we need to still remediate with your organization? They can then also pull exports out of this, so to help them remediate the data, provide that back to us in various forms, whether that's through our website or through a flat file upload. If it's clinical data, we can work with you to remediate that within your EHR as well for that. And in this, both of these roles, the executive and the analyst role, those are programs or access that we have in any of our quality measure programs. So we just customize the program for the specific areas, the quality measures and the categories to that particular program, but the same type of functionality exists throughout. So to wrap up my section, why we believe that we can be a key partner of yours is, number one, we're working with multiple data sources today. We have that experience, both structured and unstructured data, to be able to wrap our arms around it and provide you back actionable data for any type of program that you're looking to report on. We do have the ability or a measure library that expands across multiple programs. We're a qualified registry and a QCDR. We can provide near real-time performance dashboards. I'm happy to go into further examples of those at another time if you wished. And one other key point, and something we didn't touch on in this webinar, is around APM, specifically ACOs. We have great experience around population health that we can apply to your initiatives for if you're transitioning into an APM as well for that. So we appreciate your time today. I'm going to turn it back to Nathan for our question and answer session. My contact information will be at the end here. If you have any questions that you don't ask through the webinar, please reach out directly to me, and we'd be happy to help.
Okay, thank you, Mark. We're running a little bit short on time. We've had a number of questions come in. I'll get to a few of them here. If you have any questions that we don't answer, you can reach out to Mark directly afterwards, and we'll be happy to answer them for you. So first question, do you provide recommendations for measures selection? I think Christine will take this one.
Yes. So, we work closely with our clients in doing the measure selection, as Mark mentioned in this readiness assessment. We take a look at the data that's available, the specialties that the providers are in. We also want to try to optimize the MIPS score of the providers. So we take into account many different factors and aid them in the measure selection process.
Next question. Which of the MIPS eligible clinician types are optionable for ACI?
Yeah, so, and I assume this is for program year 2018?
Yes.
Okay. So for program year 2018, it basically is everyone that was optional in 2017, as well as they've added the ambulatory surgical center clinicians now are optional as well. So the ones that were optional or they're optional in 2017 are essentially the non-patient facing, the hospitalists, and then the normal extender roles, the PAs, the NPs, the CNSs, the CNRAs, they're optional for ACI. So they do not have to report it. If they do report it, then CMS will score it.
Thank you, Christine. Okay, next question. If I don't read this correctly, I apologize. We received a 2% penalty for 2016 reporting year, but we are exempt for 2017 and 2018 reporting. Our 2016 penalty affects our 2018 payments. Since we are exempt in 2017 and 2018, will the penalty be removed after 2018, or will the penalty last forever?
No, luckily the penalty won't last forever. So it's the same as in the other programs, the legacy programs that you may be familiar with. Meaningful Use and PQRS, it's really just for the payment year. And as I described, there's a performance year, also known as a program year, and then there's a payment year. And the way that it works is the payment year is always 2 years in the future of your program year. So, as you mentioned, your performance year of 2016 is going to impact your Medicare reimbursement in 2018. So when you submit that first claim in 2018, it will be penalized. But it'll just do it for that particular calendar year. So coming 2019, you should be in the clear.
Okay, thanks, Christine. I think we have time for one more. Do we know what the threshold is for receiving improvement bonus points on the quality measurement category?
By threshold, I think you mean that, I guess I'm not sure if I understand this question, but it'll be, you can get up to 10 points. And basically what they'll do is they will look at your quality achievement point score in program year 2017, and they will look at your quality in category achievement points in 2018. They won't include any bonus points in the comparison, and they basically then see if there was an improvement, and then if there was an improvement, they basically weight that toward times the 10 points in order to give you up to 10 points bonus. They don't include any bonus points in the calculation, and one thing that CMS has done is set a floor, because what they don't want to reward is bad performance in 1 year to give the bonus in the next year. So essentially what they've said that if you have a score of above 3 in terms of quality, but lower than 18, they will essentially use that as the comparison. So essentially if you had 60-point quality score for program year 2018, they would use the floor of 18 points in 2017 when they do that delta, and then give you a percentage of that for the improvement bonus points. If that answers the question.
Okay, thank you, Christine. So that's all the time we have today. If you have any questions that we did not get to, or you would like to ask any additional questions, please reach out to us directly. Reach out to Mark in the information on the slide now. I'd like to thank Christine and Mark for participating today, and on behalf of the entire SpectraMedics team, thank you, and have a great rest of your day. Take care.